Hi everyone, good morning. I hope everybody can hear me and see me okay. Just in the interest of time, we'll get started now. It's 11:01. So I just want to say good morning, everyone. Welcome to the third of DRNI's webinar series on brain health and dementia. My name is Vanessa Moore. I'm the Scientific Project Manager for DRNI. We're at the halfway point already for our webinar series. It's flown, and so this is number 3 of 5. These webinars are focusing specifically on brain health and dementia, and today's topic is brain stimulation and cognitive therapy in that context of dementia and brain health. We're very lucky to have 2 brilliant speakers with us today, Dr. Michelle Kelly and Dr. Cassandra Dinius. Before I hand over to them, I just want to say that we will have time in the end after the presentations for questions, but feel free to put any questions that you have in the chat box or Q&A box at the bottom of the screen, kind of as and when they come up. You don't have to wait until the end. So, you know, when a question pops up, just throw them in there. And I hope the chat isn't disabled like the last time, but if it is, try the Q&A box and I'll try to enable the chat. So I'll start now by introducing our first speaker, Dr. Michelle Kelly. You're very welcome today, Michelle. Thanks so much for agreeing to take part in the webinar. Dr. Michelle Kelly is an Associate Professor of Psychology at the National College of Ireland and co-director of the ProBrain Research Lab. She's also an accredited cognitive stimulation therapy trainer with University College London. Michelle's research focuses on early interventions for people with dementia, including cognitive stimulation therapy and cognitive rehabilitation. Her current projects are funded by the Irish Research Council and the Alzheimer's Society of Ireland's Dementia Research Awards. So over to you, Michelle.
Hey, Michelle.
Okay. Oh, Vanessa, you're back. Okay, good.
Oh, did I disappear? Sorry.
You were frozen there for a second, but I wasn't sure if it was my connection or yours.
No, it's probably mine. Sorry.
No, you're grand.
That's not great. Okay, I'll turn off my video and hopefully you can take over, okay?
Yes, no problem. Okay, great. Thanks so much, Vanessa. I'm just going to share my screen here. I know my Wi-Fi is a little bit iffy as well, so just maybe Cassie, if I freeze or anything, will you just unmute and let me know?
Will do.
Thanks, Emil. Okay. So I'm just going to pop back to the beginning of my slides. Oh. Let's come back to that. Okay, here we go. This one here. Yeah. So thanks so much to Vanessa for inviting us to speak on this topic, and thanks so much to everybody for joining us as well. So we'll talk about brain stimulation, I suppose maybe more so like mental stimulation and how that contributes to brain health in dementia. So first of all, I just want to highlight a couple of factors that can improve or impact on brain health. So we know obviously that there are a number of lifestyle factors that can improve our brain health. The types of factors include things like exercise and a healthy diet. So there's lots of research evidence to date to show that if we can keep our heart healthy, then we can keep our brain healthy. So the usual things, getting out and exercising and eating well, are going to be good for our brains too. Quitting smoking and moderating our alcohol intake is also really good for our brain health, and keeping socially engaged. So I think this one is incredibly important where, you know, if a person is going through any kind of an illness or a diagnosis of dementia, being able to sort of seek out social support and keeping socially engaged is incredibly important. And I suppose with any kind of supports that we provide as health and social care professionals, we want to make sure that those supports are enabling people to be able to keep more socially engaged, because actually lots of research shows that social engagement and social support stimulates our brains and keeps our brains healthy. And it's not about the number of social ties that we have, it's more about the quality. So where we can get that really solid emotional support that's actually stimulating and it's good for our brain. But what we'll focus on today is around mental stimulation, or that idea of use it or lose it. So we're all probably familiar with that saying, use it or lose it. In the context of mental stimulation, what this really is referring to is neuroplasticity, so the plasticity in our brains. So our brains have this amazing ability to be able to adapt and change depending on the experiences that we have and depending on the stimulation that the brain gets. So if we think of the brain almost like a muscle, if we exercise, our muscles get bigger. If we exercise our brain structure can change, and we can build up new connections or pathways between different neurons in our brains. But if we don't exercise, if we don't keep our brains engaged, we can actually lose those connections, or some of those connections become redundant. So it's incredibly important for us throughout our lives to keep our brains as stimulated as possible. And that really does improve brain health. And I think it's incredibly important for us to know and to bear in mind as well that that is still relevant for a person after a diagnosis of dementia. So we have this really important research that shows us that people with dementia retain that neuroplasticity. Their brains retain the ability to be able to adapt and change depending on their experiences. So with the diagnosis of dementia, there's disease in certain areas of the brain, but not everywhere. So the areas of the brain that are not impacted by the dementia, those areas, they can almost, if they're exercised, they can almost maybe compensate for some of the difficulties in other areas. So people with dementia can learn new things and they can relearn information. So keeping the brain stimulated then through different types of mentally engaging activities is obviously very important. And yes, we want to impact cognitive function. Yes, that's important. But also what I would say for us is that important outcomes are things like helping people to feel confident, supporting people to be able to be engaged. And all of that then can contribute to quality of life. Sorry, my cat is sorry, 1 second. The cat just got a bit of tin foil and was like running around the place wrecking it and distracting me. I should have kicked him out. So I do want to differentiate as well between general mental stimulation and cognitive interventions. So when we talk about mental or brain stimulation, I suppose there's two different types that we can think about. And general mental stimulation is that everyday type of stimulation that we can all do at home. It's doing the crossword puzzle maybe, or doing a bit of reading, having a conversation that's stimulating, thinking about things in a new way, or maybe doing some reminiscing, looking at photographs. So those kinds of activities are stimulating. Social engagement is really mentally stimulating as well. So get out and about, go to a cafe, go to a play, go to a movie, have a discussion about those kinds of things. That's also general mental stimulation, and it's helpful because it's social support. It's tying into the social support piece also. The cognitive interventions, these are more structured. So these would be things that would be offered or provided by health and social care professionals or psychologists, and they're structured, and there's specific types of activities that are completed within these. And that's what myself and Cassie will focus on today. So when we think about or look at recommendations around cognitively stimulating or brain stimulating interventions in Ireland, the National Dementia Strategy, was great, published in 2014, really, really important step in the provision of support for people with dementia. And it identified or prioritised early diagnosis and intervention. So identified the necessity for us to prioritise that. So when a person goes for an early diagnosis, we want to make sure that the intervention piece is also in place, that we don't have this treatment gap for people. And where we have interventions, I think anybody working in the field of health and social care would agree that it's important that we have evidence-based supports and interventions that are evidence-based. More recent development then was the publication of the HSE model of care, which again is a really important step in the progression of our ability to be able to provide adequate and appropriate supports for people with dementia. And one of the strands of the post-diagnostic support piece in the model of care is around supporting cognition, and they have specific recommendations around cognitive stimulation therapy and cognitive rehabilitation, which is what myself and Cassie will focus on today. So really, having worked in early interventions for, I don't know, it's like 12 years now, we know that the greatest evidence base, or there's a good evidence base to support or to recommend these types of interventions. And again, they were specifically mentioned in the model of care and in the NICE guidelines as well. So these evidence-based interventions are cognitively stimulating, and the two kind of main types there are cognitive rehabilitation. Now, this is called a couple of different things. I think it's called CRT in the model of care, cognitive rehabilitation therapy. It's also called GREAT, CR. GREAT is an acronym that it was named after the most recent randomized controlled trial of cognitive rehabilitation. So it was sort of renamed GREAT CR. So of course, just to make things confusing, there's 3 different things you can call it, but the structure of it is the same. And that was developed and evaluated by Professor Linda Clare in Exeter University. And then cognitive stimulation therapy, which Cassie will talk about in a little while, that was developed by Amy Spector in University College London. So I'm just going to focus on cog rehab for the moment. So cognitive rehabilitation then, it is an evidence-based intervention. So there's a good evidence base to suggest that it can support people with early stage dementia and looking at those kind of cognitive and functional outcomes. As I said already, the model of care recommends cognitive rehabilitation. And I suppose to mention as well, it is most appropriate for individuals in the earlier stage of the disease course. So it is one of those early interventions that can support an individual who has sought early diagnosis. And in my experience with working with cog rehab, we find it has really, really high social acceptability for people with younger onset dementia. So I think where maybe the services and supports, maybe some are not are quite built or appropriate for younger onset individuals with younger onset dementia might feel that they want to seek out different types of supports. Cognitive rehabilitation is an alternative that could be very well suited to the needs of individuals with younger onset. It's an individualized intervention, so working one-to-one with a practitioner. It's goal-based, which just means that the person with dementia themselves identifies what they want to work on. So I really like it because it's really person-centered, genuinely person-centered, because the person says, this is what's important to me, this is what I want us to work on. And the carer is involved as well. So a family member, a loved one, supports the implementation and the practice of the intervention. The CR sessions, usually the practitioner would identify around 2 or 3 personally relevant goals, using some kind of a goal setting tool. The practitioner then would develop a one-to-one intervention or support plan, and this would be run across 6 to 8 weeks of around an hour or an hour and a half. The types of goals that people identify are things like, somebody might say, oh, I have 5, 6, 7, 8 grandchildren now, and I am getting mixed up with their names, and it's really bothering me. Or I went down to the local golf club the other day and I started to forget people's names, and that bothered me. So face name recall does tend to come up a lot, and even something small like that might seem like something that's small, but actually if a person starts to lose their confidence in saying the correct name at a social setting, they may be more likely to withdraw from that social setting, which is actually bad for their brains. So even working on a small goal like that can be really meaningful for quality of life and indeed brain health. And things like using a mobile phone, which is important for independence, for safety. Number recall, if a person wants to use their bank card, for example, can they retain or can they recall their PIN number? So you can see each of these, it is around trying to promote as much independence as possible for people. In relation to research evidence, there's probably hundreds of studies have been done around cog rehab, and there is support to show that it significantly improves goal performance and goal satisfaction. So that's where the weight of the evidence lies. People are improving in their ability to be able to do the things that they want to do, that keeps them happy, and then their satisfaction with their ability to be able to do these goals also. There's evidence around improvements in quality of life. And for the smaller single subject studies, they do tend to show cognitive benefits, although the larger, sort of better controlled studies don't show those cognitive benefits. So again, I think it's important when we're looking at these types of interventions to be clear about what the benefits might be. While cog rehab might not change somebody's score on an MMSE or a cognitive test, it is likely to help them to be able to keep doing the things that they want to do for longer. And just to mention as well, a couple of years ago, my colleagues and I ran a pilot study of cognitive rehabilitation for people with dementia in Ireland. I'm working with the Alzheimer's Society on that one. And What we found was that we did find improvements in cognitive function or in those scores on those cognitive tests. But the reason I've highlighted this is because we found the greatest improvements for individuals who were earlier in the disease course. So again, I suppose I'm advocating for the early intervention piece, for making this available for people who have more mild symptoms or who are earlier in the disease course. If you look at our P01, that was participant 1, that individual had a lower baseline score compared to the other 2 participants. And we saw some maintenance on the first cognitive test, the MOCA, but on the second cognitive test, we saw disimprovement over time. For our participants 2 and 3, who had higher baseline cognitive scores, we saw some really impressive improvements from baseline to post-test. And those improvements on that final cognitive test, the Orbans, those improvements were maintained over time as well. So the post-test was after 8 weeks and the follow-up was another 8 weeks after that. So the follow-up was 16 weeks after baseline. And we're seeing those maintained improvements in cognitive function. And they also improved in their goal performance and quality of life. So again, I suppose just that piece around thinking about when we make these interventions available, and are they available for people immediately post-diagnosis, because that's when the ideal is around cog rehab. So with recommendations then, cog rehab, it is a clinically effective intervention. It helps people to be able to improve their everyday functioning. And as I said, the best gains seem to be for individuals who are earlier, who had higher baseline cognitive function. But cog rehab isn't widely available. Now, while it is available in some places, I know some of the memory technology resource rooms are offering cog rehab, some of the memory clinics, but we don't see it sort of routinely offered or widely available all over the country. And usually this is just because of a lack of resources. You know, resources are thin on the ground. Staff already have huge caseloads and have so much to do. It's hard to be able to implement something new, and particularly something that's one-to-one, because it does take quite a few resources, or quite a lot of resources. So that takes me to our most recently funded study. The aim of this study is to increase the availability of cognitive rehabilitation in Ireland. So this research was funded by the Alzheimer's Society's Dementia Research Award, and we're so grateful for the opportunity. And it's a collaboration between our lab in NCI, the ProBrain Lab, and Tala University Hospital. So what we did, or what we're going to do with this project is, if you look on the left-hand side of the slides, so we have all of these trainee psychologists in Ireland who need placement, right? If they're to go on to meet the PSI criteria around becoming chartered psychologists, they have to do supervised clinical placements. And typically these are voluntary placements, but they need them for their qualifications. We have a number of cohorts of students who are on master's or doctoral level courses in behavioural psychology in Trinity and in Galway. And those individuals, again, they need those placements. But they need more. At the moment, their placements are very much focused on intellectual disability services. We need more varied placements for those. So I had recognised the need for those placements. And then within the memory clinics and services, you know, the regional specialist memory clinic in Tala and the new memory assessment support services, there are new kind of post-diagnostic support pathways being created for people with dementia, with mild to moderate dementia. And there's, I suppose, a recognition of the need for these types of interventions to be made more available. So what the project aims to do then is to combine both. I mean, the psychologists need placements and the memory clinics need people to do cog rehab. So we've just joined or amalgamated these two sort of needs together, and we are creating a model where a supervised clinical placement model within the memory clinic. So we are going to offer placements to those students who need them, with a view to them delivering cognitive rehabilitation. So they have to deliver cog rehab if they get the placement. So the first phase of the project that just started in November is the implementation strategy. So those trainee psychologists, we're collaborating with Linda Clare, who has offered her new e-learning program in Great CR. So those trainee psychologists are going to conduct training with Linda Clare in delivering cog rehab through the DSIDC, and through work with our PPI contributors, they're then going to go out to people's homes, people who have been recruited through the memory clinic, and they're going to deliver cog rehab to people with dementia in their homes. We'll evaluate that. So we'll interview the people with dementia and their families and the practitioners, and we'll evaluate how feasible and how acceptable and appropriate that has been. And we'll also conduct an evaluation of cog rehab itself. So we want to look at, is the implementation of the placements effective, but also when cog rehab is offered in this kind of a model, is cog rehab effective? So two different sort of parts to that evaluation. Looking at the potential impact of this project, really just what we want to do is we want to increase the availability of evidence-based supports for people post-diagnosis. We want to be able to, based on this project, provide guidelines for scaling up this service delivery model. There's no reason as to why this couldn't be a model that's used across memory assessment services or memory clinics across the country. And then, of course, we'll disseminate the results of the research through policy papers and through peer-reviewed research, and we'll have a community event as well to share the results of the project. There's a video there on cog rehab that I didn't intend to show. I just have it in the slides. If anybody wants a copy of the slides, we can make them available. But the video is there if anybody wants to look at just a little bit more about what cog rehab is. And I wanted to mention as well that there are some resources available. So myself and a colleague wrote a manual on cog rehab a couple of years ago. There's a link to the manual there. It's just looking at different types of strategies and techniques on how to address specific types of goals. There's also a link there to Linda Clare's new website on Great CR, and it provides resources for people with dementia, for caregivers and for practitioners. And there's information there about their e-learning course. The e-learning course at the moment, it's for healthcare practitioners, but it's only available through the NHS. So as part of our funded project here, we're working with Linda Clare to try to make that e-learning course available through the HSE as well. So that's the goal. Okay, thank you so much. I'm not sure how I am for time there. Hopefully I didn't go too far over, but I want to pass you over now to my colleague, Dr. Cassandra Dinius, and she will talk a little bit more about cognitive stimulation therapy.
That was brilliant. You're doing great with time, so thanks a million. Good. I'm going to keep my camera off just so I don't jeopardize the internet, and I'll just super quickly introduce Cassie, or Dr. Cassandra Dinius. She's a postdoctoral researcher at the National College of Ireland and Maynooth University. Her research focuses on non-pharmacological and lifestyle intervention for older adults, aiming to enhance brain health and well-being. She's interested in understanding of the efficacy and impact of interventions to provide recommendations for enhanced uptake and deployment. Cassandra is also passionate about working together with interdisciplinary and interinstitutional stakeholders to build practice around public and patient involvement and public engagement with research. So the floor is yours, Cassie. Thanks very much.
Hi everyone. Thanks, Vanessa. Let me get my screen up here for everyone.
Say quickly while we wait for the slides to keep the questions coming. It's great to see them come in, so just keep them coming. Thanks very much.
Thanks, Vanessa. Thank you to DRNI for hosting this series, and thank you to Dr. Kelly for inviting me along. It's great to be able to share the work we're doing and to be able to chat about this project as an early career researcher. So for the next portion of the series here, I'll be talking about facilitators and barriers to implementing cognitive stimulation therapy groups for people with dementia in Ireland, which is the name of the project. And to start us off, I suppose let's talk a bit about cognitive stimulation therapy itself. So Michelle did a great job talking about cognitive rehabilitation. Cognitive stimulation therapy is a group-based intervention, usually for people with mild to moderate dementia. And this takes place over 14 sessions, usually over the course of 7 weeks. Now, this type of group-based intervention is meant to stimulate and engage people using a social group. So it's social in nature and it's meant to be fun and enjoyable. These sessions have different themes, and those themes then have activities that can be catered to the interests of the group. So there's a bit of bespoke delivery here depending on what people might be interested in. Now, some of the themes would be things like games or food, being creative, using money, and team-based activities. So there's certain themes that go through each of these 14 sessions. Now, these groups would be led by trained facilitators, and the facilitators or people who are interested in running one of these groups can undergo training from Dr. Michelle Kelly. These are offered. So what's important to take away here is that this is a structured, standardized delivery of a program. And there's books and supports and resources as needed to deliver this group-based program. As far as efficacy, what are the benefits likely to be? There is an impact on cognitive function. There's a study here that, or a systematic review here that looked at 12 different studies. And 9 of the 12 studies showed significant positive outcomes. Now, you might be wondering, what does that look like here at home in Ireland? And in Ireland itself, what we saw here with a project or a study here led by Dr. Kelly, it let people do what's important to them for longer. So pre versus post, after someone is a part of the intervention, there were improvements on subjective cognitive function, confidence, and level of engagement for people with dementia. And the qualitative feedback showed consistently positive thoughts and comments from people with dementia and facilitators, people saying they enjoyed the program and that they had benefit. So that leads us then, now that we have an idea of what cognitive stimulation therapy is, to the current project. The current project is looking at an implementation gap in cognitive stimulation therapy in Ireland. So based off of available data, we estimate there's about 380 people who are trained to deliver cognitive stimulation therapy in Ireland. Now, despite this, there's a gap where people who are trained to deliver this type of, or to facilitate this type of therapy, those people often don't deliver the therapy. So why is that occurring? And what are some actionable suggestions to increase cognitive stimulation therapy in Ireland? So this work is supported by the Irish Research Council on a new foundations grant. And the Alzheimer's Society of Ireland is a community partner. So we're really grateful for their help as well. This project started at the beginning of the year in January and is set to conclude in March. So let's dive in a little bit and talk about what this project itself looks like. So the project team is the ProBrain Lab at the National College of Ireland. That's Dr. Michelle Kelly and Dr. Caoimhe Hannigan. I'm Dr. Cassandra Dinius. I'm employed as a postdoctoral researcher on the project. And Eve Larkin is a research assistant that's working with us as well. So leading more into the current project and the research question, cognitive stimulation therapy at this time, to our knowledge, is not routinely offered in memory clinics or memory technology resource rooms across Ireland. It's offered in one location of all the Alzheimer's Society, but in comparison, it's mandated in 85 memory clinics in the UK. So the ProBrain Lab came to this wanting to understand what maybe some of the facilitators and barriers are, and to be able to then develop recommendations. So given what we know, cognitive stimulation therapy is an evidence-based intervention and it's mandatory in other countries. So we're curious to then look at, in Ireland, in this Irish context, what might be barriers to why this is not being offered more frequently. And one of our goals with this is then to provide a report to the project partner, Alzheimer's Society, and also to the community at large, detailing recommendations that might help to overcome some of these barriers. So we're using a multifaceted approach. We're asking the people who have been trained to deliver and to facilitate these programs. We're asking policymakers, we're asking healthcare providers, and we're asking people impacted by dementia. So the goal here is to look at the problem from many different angles to get a very holistic understanding. And then we'll share this with the community at large, developing these supports. So the study information will be shared with different relevant groups. The online survey then is going to be distributed to anyone who is trained to deliver CST, including those that have or have not been able to run groups after completing the training. This will consist of a questionnaire that's distributed on SurveyMonkey. We'll gather information on demographics, the training itself, implementation, whether or not people have been able to deliver this type of program. And then we're also asking questions of policymakers, healthcare professionals, and people impacted by dementia. And we're doing this in either one-on-one interviews or small focus groups. And this is based off of the questions we're asking are based off of a template from the Consolidated Framework for Implementation Research, or the CFIR. So here we're trying to gather insights about domains of implementation and examining when and where barriers might be, and then also talking about potential strategies to compensate for those barriers. So for example, asking people, what do they know about cognitive stimulation therapy? What might interest them about it? And what might limit their involvement? So where we're at right now, the online survey data, that's still ongoing. We're still collecting that information. But we do have a bit to share with you today of our qualitative analysis. So for focus groups and interviews, we've talked with 9 healthcare providers and policy professionals and 10 people with dementia and their carers. So on this, we're doing some qualitative analysis using framework analysis in a software called MaxQDA. This is ongoing, like I said, but I'm happy to share some preliminary results of what we're starting to see. So some findings that are emerging would be a general lack of understanding or awareness of cognitive stimulation therapy. So here is a quote, "I don't see why we should be given that burden. Like, we have the burden of getting her through the day, you know, and looking after her, make sure everything around her is okay. Surely that should be a basic thing that's provided for us." We also see a lack of the awareness of the evidence base for cognitive stimulation therapy. People report saying, we were told there's nothing, there's no treatment, nothing that could help your situation, just things to keep you interested in activities, but they didn't say that can help with your symptoms. And as Michelle said, also insufficient resources on the ground. And we've heard many different stories of people going through the diagnosis process and not being really sure where to proceed post-diagnostic. So here's an example. They just brought me in and they didn't actually tell me. They told my husband. He was sitting alongside me. They said, "She has early onset Alzheimer's." And my husband was in shock and said, "How long has she?" They were talking as if I weren't there. And I was really upset over that. And so then they just sent me home. And that was it. No more. Nothing. So these are some of the early things we're starting to see as places to be able to target for reducing barriers to access to cognitive stimulation therapy. So the impact we hope to have with the project is that we'll have some peer-reviewed publications adding to the literature. This will address maybe the evidence-based interventions and how they're implemented, maybe address that gap We'll also be assisting Alzheimer's Society and other organizations to address any service delivery issues by helping to identify facilitators and barriers. And then we also believe there's an impact here on the lives of people living with dementia and their loved ones. We're doing that by increasing the implementation of CST and the awareness of it as well. So a few of the ways that we'd look at doing this is increasing awareness itself. This, I think, has already started happening in the community. We're recruiting people who are interested in talking to us about their experience. And even in those conversations themselves, we're starting to raise that awareness of what CST is and the evidence around it. So those conversations have started happening. The ProBrain Lab is also looking to establish a research consortium for the development of future funding proposals. So that's a larger scale project. And then we'll have review publications and conference presentations that will help raise awareness and develop discussions with the scientific community and policymakers and clinicians. And then we're also very interested in sharing this information with the general public, being able to summarize those findings and provide recommendations. So we'll have a community event to be able to share those results and raise awareness. We also hope to host a workshop and develop an online community of practice for those people who are trained to deliver CST as a way to have resources amongst themselves. So in general, we're hoping to have increased awareness of cognitive stimulation therapy, both in the community and among service providers. We hope to gain a better understanding of the facilitators and the barriers to implementing cognitive stimulation therapy in Ireland. And then finally, knowledge on how we can utilize resources most effectively to ensure that increased implementation. And just thanks again to all of our partners and to Dr. Kelly and to DRNI for having us today. Thank you.
Thanks so much. That's brilliant. We've loads of questions coming in, so I'll start going through them now, but just to say thanks so much. I learned so much in the last 40 minutes, so really, really interesting. Thanks so much. So I will start, just there's a few kind of practical questions. How can a person put their name forward for this COG Rehab trial clinic? One gentleman, for example, saying, I live in Kilkenny, is there a facilitator near me? Is there a way to kind of get involved?
Yeah. Hi, John. Thanks so much for those questions. So in relation to the COG Rehab trial, it's at the moment, we're just recruiting through the Memory Clinic in Tala. So if a person has gotten their diagnosis through that Memory Clinic in Tala, they would be the individuals that we're recruiting. And I know, obviously, for individuals who haven't come through that Memory Clinic, it is disappointing. And it's, you know, we only have like a limited number that we can recruit at the moment. But the hope is that once that model is, like, once we're able to evaluate and show that the model works, that hopefully it's a model that can be rolled out across the country. Now, that's not, so there is COG Rehab being offered in other places as well. So some of the memory technology resource rooms are offering COG Rehab. And I did look up if there's one in Kilkenny, and there is. Now, I don't know if the one in Kilkenny are offering COG Rehab, but it is absolutely worth a try. You could ask. So it says they're open every Tuesday on the grounds of St. Columba's in Thomastown in Kilkenny and in Sacred Heart Hospital in Carlow. So it is probably just worth checking in with them and seeing. Also, there are dementia advisors in a lot of the local areas. So if you know who your dementia advisor is, you could link in with them and they might be able to signpost you if CST or if COG Rehab is being offered in your area, they might be able to signpost you to that. I suppose the difficulty is that we are not seeing that it's widely available, and that's where myself and Cassie and the ProBrain Lab, where we're trying to work at making it more available. So it is really frustrating for people, and I understand that when we talk about these things and then we say, but they're not actually widely available. But I suppose that we see that, and the purpose of the project is to try to make it, to ensure that these are rolled out more widely in the future.
That ties in a little bit to another question. Can people be signposted to these services after having a diagnosis? So it's basically to kind of see if there is something in your area and then contact them and see if they offer it.
Yeah, and I really take that point as well about being signposted, because one of the quotes that Cassie put up is that people, when we interviewed people, they were frustrated that they have to do all the work to try and find this stuff. They're saying, why can't we just be told about this? And we completely agree with that. So again, another aim of the research that we're doing, or the projects that we're running is that we're trying to make that pathway more obvious. You know, at diagnosis, people should be given information about where these kinds of interventions are running, how do you access them, and it shouldn't be up to people to keep looking at them. So the signposting, it does happen sometimes. So obviously there are some places where the signposting does happen, but I think the experience that people get at diagnosis varies widely depending on where they go. So I completely agree, the signposting needs to be improved. And I think through the new model of care and the new memory assessment support services that are being set up, hopefully that signposting will improve. But for now, it's sort of maybe contact your local dementia advisor and see what's available in the area. Because even when we Google this stuff, it doesn't really come up. And again, that's something that we want to address with the project.
Absolutely. It's definitely something that's sorely needed anyway. The next question is for Michelle. Thank you, Michelle, for your presentation. Is there an overlap with cognitive rehabilitation and the work completed by occupational therapists for people living with dementia? If the goal of CR is to enhance everyday functioning, should occupational therapists be more involved in the trialing and development of this approach due to their unique skill set?
Absolutely. And I saw in the chat as well that something else came in around OT students.
Yeah.
So actually predominantly it is occupational therapists that offer cognitive rehabilitation, and the memory technology resource rooms are manned primarily by occupational therapists. So yes, there's a really clear role there for OTs. So at the moment in Ireland, OTs are already the ones who are offering cog rehab. I suppose what we're trying to do is we're trying to cast the net a little bit wider and trying to get more individuals trained up and available to be able to deliver it. And the question in the chat there as well was around considering OT students for the project. That's something that we want to work towards in the future as well, where, a more grassroots approach. How do we look at maybe training in the colleges for OTs, or, anybody that's really going to be able to deliver these kinds of supports. And occupational therapy is a really obvious one as well. So how do we link in with OT, provide these kinds of placement opportunities for those students as well? We're not being exclusive. I suppose the project only allowed us to do a small amount in this length of time, and we want to make this as widely available as possible. So absolutely agree that OT should be included, and as I said, they're the ones who are actually already offering it in Ireland at the moment.
Great, thanks a million. Yeah, there was a lot of questions around OT and other kind of healthcare professionals who can provide it. There's another question, is CST beneficial for mild cognitive impairment?
Yeah, so CST is very adaptable. So the way in which the group is run can be different depending on the group members. So if there is a group of individuals who have mild cognitive impairment, the group can be tailored to that. And then similarly, if there was a group of individuals who had maybe more moderate impairment, it can be tailored to that too. So yes, you just need to sort of, I suppose, the group facilitators need to make sure that it's pitched at the right level depending on the participants that take part.
Great. Another person is wondering where the sessions are taking place, in community, or is it in a hospital setting?
Well, I mean, I suppose both. So with cognitive stimulation therapy, which is the group-based one that Cassie was talking about, that one is typically more often, I suppose, it's offered within sort of maybe daycare services or those types of services, maybe respite services. We ran a pilot where it was ran in the community, and that worked really well as well. So where we see this more widely available, I would like to see community provision. With cog rehab, it can be done in a hospital setting, but actually that's not what we recommend. We recommend that it's done in people's homes. Because the goal of cog rehab is really about helping the person to be as independent as possible with their daily tasks, and you just get better generalized, and you get the intervention impacts generalized better when you're actually running the intervention at home for people. So at home or as near to possible for those that individualized cog rehab.
And so this kind of ties into what you've spoken about a bit, but I'll kind of come back to it again because there's a few questions that are similar. Is there current referral pathway for appropriate patients? Do you need a dementia diagnosis to access the services, or can somebody with cognitive impairment access them? So basically, it just depends on it, whether it's available in your area or not.
Yeah, it depends on whether it's available in your area. I mean, I would say we would hope that it would be available for people with mild cognitive impairment and that don't have that diagnosis of dementia. And, you know, so what we see in the memory clinic happening is individuals come in through the memory clinic and may not meet diagnostic criteria for Alzheimer's or some form of dementia, but they're still experiencing some kind of impairment. So at the moment, I think the signposting is that they would be referred on to the brain health kind of pathway. And we would hope then that through this project that we're running at the moment, that there would be additional supports available, maybe cog rehab if people were interested in that.
There's a couple of questions as well around kind of training as a facilitator. You know, how do you train up? Do you as a volunteer, as a healthcare worker? So I know you've touched about it, or, you know, maybe just, you know, looking at it again, can anyone train as a CST facilitator, or do you need some kind of...
So I'm looking at Claire's question there, and I know there's a couple of similar questions. So does it need to be delivered by psychologists? Definitely not. Nurses and OTs, can they deliver it? Definitely. So with CST, with that group based, it's really just anyone who has any experience with dementia. So anybody who is experienced, and then, you know, ideally you would do the CST training too. But there are manuals that are available around CST. So, you know, even if somebody was sat in on a group and they had the manual, that would be fine for them to be able to run that as well. With cog rehab, with that one-to-one intervention, it used to, about 10 years ago, the idea was, oh, it could only be run by psychologists. But that idea has just been dropped because, you know, it can absolutely be run by nurses or occupational therapists, or, you know, again, anybody who has that training. So I do think we need to be less exclusive and more open and say, look, if somebody has experience working with people with dementia and they have training in the area, they're able to provide this kind of support or service. And Claire just mentions there that Exeter has that online training. So there's a link in my slides that actually takes you to that training course. Is that sufficient to deliver CRT? I mean, not if you have no experience at all with working with people with dementia, but if you have experience and you conduct and you go through that training, I would say it is, you know, it is something that gives you those tools to be able to work with people. The training that's available now, I think there's a general kind of a training program that's available to everybody. There's more intense training, as I said, it's available on the NHS for staff of the NHS. But we're working with Linda Clare to make that available through the HSE to staff in the HSE as well, and more widely available.
Great. And there was another question specifically. So SCT versus maintenance SCT. What is the research that suggests which to go with?
The research suggests that the original 14-session CST is more beneficial. So maintenance CST has some evidence base, but it's more kind of just to maintain the effects of the original 14-session program. So the key evidence is around get the first one in first, and that's the 14 sessions across 7 weeks. And as Cassie was speaking about there, there's a manual for that as well. Maintenance CST is designed to be run over an additional 24 weeks, once per week. So it sort of maintains the effects. But again, I suppose the NICE guidelines would say, go with CST first. And if you've got all the resources and you can go ahead with maintenance, then go for it. But the main one is the priority.
And there's another question, is CST available for dementia in Down syndrome?
Great question. There's been loads of work happening at the moment around adapting CST for Down syndrome. So I was working with Sharon Hardiman, I know, has a project. Actually, she presented at the research day. Her colleague presented at the research day on that. So CST is being adapted for individuals with Down syndrome. There's a lot of work happening in that at the moment. There is, as far as I know, there's no manual, but there are people in Ireland and indeed in the UK who are working on that. There's a website, the International CST Centre in University College London. They have a lot of research ongoing as well. So what I would say, Nicole, is that CST is adaptable and there are adaptations that can be made. And if you wanted to pop me an email, I'm actually just going to put my email into I know my email was on the slide, but I'm just going to pop my email into the chat as well. If anybody wants to follow up with me, even just to get linked in with somebody who's doing CST for Down syndrome or any other questions, do please drop me an email. Sorry, I'm distracted now because I'm trying to type my email address and talk at the same time. There we go. I can't do two things at once.
Yeah, there were a few questions also around getting the slides. So Michelle and Cassandra, would do you want to send them to me? And if people want to email me and I can send them out, or if you want to email Michelle directly, or maybe Cassandra as well, you know,
Maybe
so
if we
people
do
can
it
have
through
them.
you, Vanessa, because
Yeah,
like,
maybe that's the
Cass,
easiest.
Yeah, our slides are separate at the moment, so we can send both to you and you can amalgamate and send them out.
I'll put mine in my chat, or my email into the chat as well. Yeah, that's there. And if it's okay, I have a question. So obviously, you know, so much is contingent on, you know, the service being available and, you know, funding being available and stuff. But, you know, in a perfect world where you had, you know, all the funding you needed and, you know, everything was available and you had all the, you know, staff and everything, like, how would you envision, you know, both of you, how would you envision the service, you know, of this to people, you know, whether with mild cognitive impairment or with dementia? Like, in an ideal world, how would you set it up and how would it work? How would you see it functioning?
Yeah, like I think you've made a good point there, Vanessa. I think, you know, working with Sean Kennelly at the moment on this project and Garrett McDermott, the idea here, or the dream, is that there is a suite of services available for people. So when somebody comes through and gets their diagnosis, there's almost a menu of, would you like to do this? Would you like to do this? There's lots around the brain health pathway and those kind of pathways that have been highlighted in the model of care. So how we would see that running would be that there are groups running, either being provided within services. So let's say, for example, maybe some Alzheimer's Society services are running CST, or maybe some dementia advisors are offering cog rehab, or in the memory technology resource rooms. These are groups that are already running, and then that the clinicians can refer from there, so that there's a direct pathway. They can say, oh, I can see you're living in Kilkenny, for example. There's a memory technology resource room 5 miles from your house, and they offer cog rehab. So I think we have to just, it has to be about more joined up thinking. We need to know what each other is doing. This is the one thing that myself and Cassie and the other colleagues on the project found, is that if we try and look up information, we know CST is happening in some places, but we just don't know where. We don't know where to find the information. The same for cog rehab. It's like the left arm doesn't know what the right arm is doing within the whole dementia service provision area. And I know it can be difficult to try to create those channels of communication, but it's essential, because if you go to West Cork and you go into your GP and get a diagnosis of dementia, that GP has to know about what is available and that these types of things are available and where are they. So I suppose, I don't know if that actually answers your question, Vanessa, but that's just a pet peeve of mine.
No, I mean,
Cassie,
it's just,
I don't know, do you have something to add to that?
Yeah, if you, no, okay.
No, I think you're spot on. And that's just what we keep hearing from people with that lived experience, you know, is it's overwhelming to try to navigate. They're trying to find information. And I think you're right. It's all about being able to link in and have everybody in the know of what's happening, so people feel empowered that they can then select what might be the right path for them, based off of what their own desires and needs are.
And just to say as well, I mean, there's amazing work happening. This is all stuff that's like on the way, kind of, resources pending. But the model of care has really set out this really important, you know, model, obviously, for how what dementia service provision should look like. And there's a real appetite and real movement towards having those memory assessment support services and having that post-diagnostic pathways set up. I know it might take time, but I suppose there's definitely positive change on the horizon, and there's lots of work happening in lots of different areas with lots of different groups.
Yes, it's nice to hear kind of you know, something positive coming, you know, in the pipeline. It's really great, and I'm just actually being flooded with emails as we speak from people wanting the slides. So it's really great to see so much interest. I don't know if anybody has any other questions, or if I missed a question. I'm just going to let me see. I don't think I missed anything. I
know I'm scanning them here. I think we might have addressed.
I think we just both, because they were some of them were a bit similar. Oh yeah, the OT students. Yeah, it seems like OTs should be doing this as well, judging by the comments. Yeah, I think that yeah, I think that's more or less it. Well, listen, then, you know, in the interest of time, because we're nearly at time anyway, I'll just say thank you so much. And it's, you know, really, I've gotten, I don't even know, probably about 10 emails at this stage. So there's a huge interest in this area. So it was really great to hear both of you speak on it. So thank you so much. And you know, it's all being recorded, so you can come back to it. It's going to be posted on DRNI's YouTube page, hopefully probably tomorrow, and by the time I actually get to upload it and edit it and stuff. So that's you can find it then, and obviously get the slides as well. So just send me an email and I'll send you on both slide decks. So next week we have webinar number 4 of 5. That'll be at the slightly earlier time of 10 a.m. instead of 11 a.m. So that's reflected in the Eventbrite reminders. But if you've signed up for all 5, you know, just to be conscious that it's at 10 instead of 11. And the topic next week is brain-specific post-diagnostic support. So, you know, might be slightly connected to this. We'll be joined by 2 speakers next week. Kathy McHale, who's an advanced nurse practitioner at the Memory Assessment and Support Service at Tala University Hospital, and Anya Bennett, who's a dementia advisor from the Alzheimer's Society of Ireland. So that's next Wednesday, 6th of December at the earlier time of 10 a.m. So yeah, I just want to say thanks again to everybody who attended for all your questions, and just to say to our fantastic speakers, Dr. Cassandra Dinius and Dr. Michelle Kelly, really thanks a million. I learned so much, and it seems, you know, very much the consensus of everybody who attended that they learned a lot as well. So wishing you guys the good rest of your day, and the same to everybody who attended, and we will hopefully see most of you again next week. Thanks so much.
Thanks so much, Vanessa.
Thank you.
Thanks, everyone. Bye.
Bye.